So good evening. My name is Kent Dix and I'm CEO of Life 365. Welcome to our fifth in a series of webinars related to COVID-19, telehealth, and remote patient monitoring. Before I introduce our panelists this evening, I want to take a minute and thank all the healthcare providers, first responders, family caregivers, home healthcare workers, child care providers, food and grocery delivery, transportation, healthcare manufacturers, and many others. Thank you for all your service. I also want to let you know that everyone will be on mute and that we will accept questions via chat and try to entertain a few questions throughout the webinar. Some of you have already shared with us questions that we'll actually share with the panelists through this webinar. We have received some time for questions at the end. If we don't get to your questions, we'll answer them after the webinar and post the recorded video on the life365.health website tomorrow. Now, I want to take a minute and introduce our distinguished panelists. First is Gary Wald, is a senior executive with business development, operations management, marketing consultant, and advertising agency experience. He is currently the managing director of Incubator Partners. Gary has spent the last 15 years launching and building new companies in the telehealth industry, both as a senior executive and as an independent consultant. His work drove successful market expansion, market penetration, and market share growth, while also enhancing return on assets. He was one of the co-founders and executive vice president of Teladoc Health, the first commercial telemedicine venture in the United States, and today a public company with over $10 billion valuation. It's actually more today, right, Gary?
It is.
So subsequently, he consulted for other telemedicine companies, helped hospital groups add telemedicine to their suite of services, and most recently helped launch the Teledentist, the world's first teledentistry company. Welcome, Gary. The next guest is Harry Glorikian. Is an influential global business expert with more than 3 decades of experience building successful ventures in North America, Europe, and Asia, and the rest of the world. Harry is well known for his achievements in the life sciences, healthcare diagnostics, healthcare IT industries, and the convergence of these areas. He is a sought-after speaker and holds 4 US patents in telecommunications, with others pending. Harry currently serves as a general partner at New Venture Funds. Before joining New Venture Funds, Mr. Glorikian holds an MBA from Boston University and a bachelor's degree in biology from San Francisco State University. Harry has authored 2 books, Commercializing Novel IVDs, A Comprehensive Manual for Success, and Moneyball Medicine, Thriving in the New Data-Driven Healthcare Market, and the host of Moneyball Medicine podcast. Welcome, Harry. And then Dr. Alan Pitt. Alan Pitt is a professor at the Barrow Neurological Institute in Phoenix, Arizona, the country's largest center of excellence for the neurosciences. Over the past 15 years, Dr. Pitt has been an advisor to large healthcare systems and state government. He has functioned in a myriad of roles, including founder, advisor, board member, and executive for several small to mid-cap companies in the healthcare IT and device space. This includes cloud-based imaging, robotics, telehealth, and AI. In addition to successful exiting multiple ventures, he has 3 patents, 1 in health IT, 2 in device. Dr. Pitt has been a national speaker on issues related to cloud-based computing and healthcare. He is an adjunct professor at the University of Arizona School of Public Health. Welcome, Alan, Dr. Pitt.
Thank you very much.
So one of the things I do at this stage is I go through and talk about, sorry, there's people saying I have an echo. We'll take care of that in a second. We talk about a couple different questions. 2 weeks ago, we had 2 million people in the world that have been diagnosed with the coronavirus, COVID-19. And this week, the US alone has topped over 1 million people that tested positive. We've had 2,000 deaths in the US 2 weeks ago, and today we are double at 60,000. There's 5.5 million people have been tested to date out of 330 million people in the US. Communities have started to open back up. Healthcare resources have been strained to capacity. Are we starting to see a flattening of the curve? That's one of the things I want to talk about today, and we'll segue that into telehealth. Did self-isolation help? What role did telehealth play in the current flattening? Today, you can't turn on a TV without seeing a commercial around telehealth, telemedicine, telebehavioral health. So Gary, as co-founder of Teladoc and now with teledentistry, when you started many years ago, first of all, where do you think this was going to go? That was one of my questions. But I kind of want to segue to a question about today. I think today Teladoc actually announced some pretty outstanding earnings reports on the market. So can you share with us, your outlook on telehealth and, and the industry in general?
Well, thanks, Ken. Thanks for having me. I think it would be insightful to say, where are we today, but also to go back a little in history to share with you how it got started. Teladoc reported earnings today. They have over 43 million members at the end of Q1. That was up from 27 million at the end of 2019. They did 2.1 million consults in the first quarter. That was a 92% increase year over year. In 2019, they did 4.1 million consults. Growing the stock prices. The stock price today was $177, and they went public in 2015 at $19. So those of us who've held on a few shares, we're happy about that. But it was a long road getting here. And if we remember kind of where did telemedicine start? Well, actually, I'm going to go back in history. The Civil War, they used the telegraph to communicate to the battlefield for doctors how to treat wounded soldiers. And the government has evolved telemedicine. They've used it with astronauts. They've used it with rural Native Americans and other kinds of military uses. And it was actually Dr. J. Sanders in 1960 who built the first kind of working model of the telemedicine system as we think about it. Jay went on to become the president of the American Telemedicine Association. And so it was in 2002 that the Teladoc concept was born, and it was born with Dr. Byron Brooks. Byron was a former NASA flight surgeon who was working at the University of Texas Medical Branch, and he had put together his engineering, medical, and telecom expertise and was serving the inmates in the Texas prison system with telemedicine. And he approached his good buddy Michael Gordon and said, let's create a telemedicine service. Michael, who was a consummate entrepreneur, was unemployed at the time. He had just sold his company, a successful company called Internet Global, which was the first DSL company. And they agreed to partner, and they created Teladoc Medical Services. They had a vision, and they had a direction of how to go forward. I met Michael in 2003, and my eclectic background seemed to fit a need of what they wanted to go. I had business development experience, 5 years with GTE Verizon, leading early days of ISP and e-commerce. I had marketing experience from major advertising agencies and had run the international division of NBC. And I had medical device experience, having been a VP of marketing at Medtronic in their insulin pump division. So I joined the company as VP of marketing in 2003. And I stayed there until 2008 and helped them build the doctor network, helped them sell to customers. And in those days, early companies, everybody's always selling. Our business model initially was to sell to corporations. Let's add this as a service that you offer employees. Our business model was a per employee per month fee to the corporation, and then a $35 copay to the patient.
But Gary, let me ask you a question really quickly. What did you see different? Because I'm sure there were other companies, like you mentioned, Jay Saunders, who was known as the godfather of of telemedicine that's out there. What did you see different at that time that you did a little bit differently to make adoption start to take off, right? I mean,
there was no commercial service at the time, Kent.
Right.
And it was a time when medical costs had risen dramatically, up 33% in the prior 4 years, which was a big increase.
Yeah.
And they were beginning to consumer-directed healthcare was starting to be talked about. And so giving employers and giving consumers a chance and a choice was a direction we wanted to take. And we wanted to get a speedy, fast response for the patient. We also remember that there's an increasing shortage of doctors in this country. And the only speedy service at the time was a 1-800 nurse line. And many of the managed care companies were giving it away to their corporate customers. The difference is that nurses back then could not prescribe medicines, where Teladoc, because they were licensed in the state, could prescribe medicines, obviously never a narcotic or a lifestyle drug. But we could talk to somebody and we could make a diagnosis and we could then prescribe medicine. And it was interesting. There were a lot of naysayers. You can talk to somebody on the phone and really diagnose. And Dr. Bob Kramer, who was a pretty renowned pediatric pulmonologist, was the first chief medical officer of Teladoc. He said to me, we're trained in medical school to ask the right battery of questions to get patients talking. And if you talk to a patient long enough, they'll tell you exactly what's wrong with them.
Right.
That's the concept we applied. We got phone calls and we turned to fast response.
Did you initially start with video when you started with this, or did you just do phone?
Audio, just telephone.
Yeah.
Just right. Telephone. A patient would call in. First of all, the patient had to sign up and register. We had to get the patient's prior medical history. We were big believers in that. The doctor had to know what chronic diseases, what meds that patient was taking before they could try and diagnose what was wrong with that patient at the moment. And so patient would call in, leave a phone number, and the doctor would call them back.
Right. So Alan, I want to switch to you really quickly, from this. I mean, it's a great introduction for the Teladoc side. I know you've worked with EmergeMD, you've worked with Avizia, you are a practicing physician at Barrow, right, that's out there as well. What was your first introduction, right, to telehealth, right, from that, and from your perspective?
So thank you very much. Appreciate being on. I think whenever you want, I've been a serial entrepreneur in healthcare, done a lot of different things. I think it always takes two. I've actually got an ebook I'm almost ready to write called Being a Midlife Entrepreneur, basically for physicians and other professionals who really can't afford to be in a garage at midlife. For me personally, my always takes two. My other person was a guy named Shez Bartovi. We had met in the mid-90s. We trained as neuroradiology fellows at Barrow together, really became fast friends, joined in a clinical practice together. Shez is a brilliant person, went from neuroradiology to chief digital officer of Dignity and now runs all of life sciences for Amazon. He's my Persian brother from another mother, as I tell people. He and I were doing lots of things. He built a company called EmergeMD, which was looking at the ways to facilitate clinical trials, collecting data from patients, nurses, doctors across multiple institutions to try to facilitate that from a technical structure. I looked at this thing and I had done some other stuff with Shez, and I told him, I said, hey, you're collecting information from disparate sources. I said, this is telehealth. Have you ever thought of just adding audio and video to this platform, and we can convert this research platform into a clinical platform to basically do telehealth? You
guys were really doing peer-to-peer consultation, right? Is that right? From physicians in emergency room?
Yeah. So I think it's really important for your audience to understand when you say the word telehealth, it means different things to different people.
Yep, it does.
And so telehealth can be what I call the walking well. A lot of the Teladoc experience is really patients who, their barrier is not high enough to get in their car to drive into an urgent care or an ED. They've got a headache, they've got a fever, they've got some problem they're worried about, but they sure as heck would push a button and see somebody. There is also remote patient monitoring, your space, Kent, which is basically how can I take care of the chronically ill? And then there's the question of how do I take care of the more acutely ill that may be functioning in a hospital in some way, shape, or form. And largely that's been a niche play in terms of behavioral health and stroke to date. I think what you're seeing is a merging of things coming together where Teladoc, Amwell are really looking to get out of the consumer-based space into the acute space. EmergeMD kind of started with this idea, we knew hospital practice pretty well. We were looking at ways that we could facilitate workflows, audio, video, to be able to do things in the acute space. And we were pretty early. We actually got Cisco to give us a contract for WebEx early on. Cisco said that they usually didn't sign these kind of contracts for companies with less than $1 billion in revenue. Obviously, we didn't, nor never got to $1 billion in revenue with EmergeMD. But we were able to integrate WebEx, which at the time was the best possible tool, into EmergeMD, and we were going down the road with EmergeMD for quite a while. And I started speaking and writing on telehealth, got to know the Avizia guys. And by then I'd actually left EmergeMD, was lightly advising them. And when Avizia came on the scene, that was a Cisco spinout. Really, it was the carts that Cisco was providing. They were looking to grow that business rapidly. I had conversations with the Avizia leadership and suggested that they either needed to build or buy software to enable workflows and more acute care to assist them in their cart business. And I think Mike Baird astutely saw the opportunity to accelerate growth into the market with the acquisition of EmergeMD to buy not only their software, which was largely a software-based company, but also to accelerate their growth through acquisition of their customer base. And so that caused the merger of Avizia and EmergeMD. And then I guess it was now 2 years ago, American Well acquired, well, there was a merger, it's more of an acquisition, but it acquired Avizia. So you now have the joint Amwell. And for all intents and purposes, in today's market, you have American Well, you have Teladoc. In the federal space, you have Global Med, and then you have a lot, a few other players in that market space who are all looking to figure out what is their niche play, where do they operate in there, and they are all on a spectrum of walking well through acute, and they're looking for other opportunities to extend their business. I personally am very focused right now on how do I make telemedicine ubiquitous in the acute setting. And right. I recently wrote a piece called In-Hospital Telehealth is Not an Oxymoron, because most people think about telehealth as what Gary's doing, which is I click a button, I see a doctor for my headache. And if we really want to bend the cost curve and take care of our patients, there are huge opportunities to enable video so that doctors can come see patients who are actually in hospital. Families can come see their loved one, particularly in this time of COVID. I've had some personal experience with that recently that's been a little rough, we can talk about. But the idea of, if you look at where the dollars are spent, they're spent on chronically ill, acutely ill. The walking well is important, but that's not really the thing that's driving up our super high spend on healthcare. And so I see opportunities that collaboration can really change the way we care for one another.
Makes a lot of sense. So Harry, from your perspective, you've heard all this, you've seen the marketplace. Let's go back a long time in the past, like 6 weeks ago. How did COVID-19 actually change, all this, right? As far as what was put in place by Gary and by Alan, that's out there, and now moving it forward, into a new form of medicine. I mean, I call this webinar the new normal. I've just stole that from everybody else that uses the phrase, right, nowadays. But it kind of is becoming the new normal. Do you think that people, they were kind of reticent and kind of holding back from adopting on telehealth from a bunch of different perspectives, and we can go through those. Where do you think it's going in the future, right, from your perspective?
Well,
and how can it help COVID-19? Sorry about that.
Yeah, no. the issues are, most of the barriers that we tend to see end up being either artificial, bureaucratic, or just to slow things down for the most part. Sometimes logic fails in these things. And you probably saw the biggest shift come with the Reinvestment and Recovery Act and then the Affordable Care Act. Gary, I think one of the big turning points for Teladoc, in my opinion, was the CVS deal. That really showed me that this is now going to take on a bigger role in the space. And some of the final barriers, and let's assume they stay down now because of COVID-19. And I don't think COVID-19 is going to go away anytime soon, from what I'm seeing. So, the longer that these barriers stay down, the harder it's going to be to put the genie back in the bottle.
Harry, I would agree with you. I think that COVID-19 has created impetus for telemedicine services where people had no choice and doctors had no choice. I got calls from gastroenterologists saying, could you help us implement a telemedicine service for our patients? They hadn't thought about it before, but now they had to. And likewise, the telemedicine, Dexcom has been a very valuable asset in hospitals where you have a lot of diabetes patients with suffering from COVID, and nurses don't want to go in there time and time again to test blood sugars. And so they've been buying Dexcom continuous glucose monitors and putting them on patients and testing their blood sugars and keeping that part under control.
It's interesting. Go ahead, Harry.
I was going to say, there's somebody asked a question of, do I think diagnostics will change telemedicine? I think that the diagnostics, as you're talking about, either remote diagnostics or certain point of care diagnostics, are going to enhance the information coming back to the practitioner to be able to better gain insight into the patient population. But I'm seeing places like, there are places that I think we're way ahead of the curve. You look at places like Ochsner, I think they're now up to, the last number I heard, they were seeing 4,000 patients a day through their telemedicine program, and sort of talking about how to roll it out there in a, implementing change management and, education systems for their docs and getting it going. There are other places that really didn't have anything in place, and I think they're scrambling. But I could say the same thing for every educational institution out there. I think the same pattern is happening. Some people were ahead and easily implementing, the next phase, and some places are woefully behind. But I don't think telemedicine is going away. And you asked me where I think it's going in the future. I would tell you that if it stays the way it is, you're going to see big tech companies step in a very big way. Yeah. Because they're going to be able to carve out a space for themselves that medical companies are going to have a harder time holding on to.
Harry, I'm going to take an alternative opinion here, and so I don't think telemedicine is going away either, but I think it is. You really have to think about who's going to win here, how they're going to look at it. I think it's super interesting to look at Teladoc. And Gary, I applaud you for building such a huge business, but there was one point where Teladoc almost died as a business, and that was, and largely they flipped their business model and changed how they sold, how they went to market, which really saved, and you may have been one of the guys who did that, but really saved that company from.
And what was that? What was the flip? What was the model that changed?
It was how they sold the service. Gary would certainly know more than I do, but my understanding, this is secondhand, my understanding was it was how the service was sold and who they were selling to. It was going away from employer patient and more directly to the payer space that really flipped the business model and made Teladoc into kind of the global leader it is today in that space. And I think it's the important thing there is to understand that the business model, less the technology, more the business model, how are you selling that service? It's absolutely key to anything you provide. And if you can figure out a business model where people want to buy it, tech will follow. You can always build stuff. To Harry's point, I don't think the future of telemedicine is in the tech companies. I think the building blocks to make telemedicine are fairly commoditized now, by and large. If you want to set up a technology-friendly telemedicine company, you've got pieces that you can do. I can put a bunch of really smart engineers in a room that can come up with a pretty good solution. The key for successful growth of telemedicine is figuring out a reason why providers want to do telemedicine preferentially over their other opportunity, which is their brick and mortar practice. In the world of COVID, well, that's obvious. I don't want to get sick, right? Or I have no other way to take care of my patients than telemedicine. At some point, this is going to burn down, and there's going to be a tendency for people to go back to whatever they're used to doing in terms of practice. In order for telemedicine to grow, I've told lots of people talk about telemedicine as being a demand problem. Can we get the consumer to use it? I have no doubt that people will use telemedicine all day long if it's provided to them. There is no problem with demand. It's really a supply problem that you have to address to grow telemedicine. And when I mean supply, it's a supply of providers who are going to pick up the phone and get on the video and participate, because you have to realize that the provider is king in their current environment. Everything is set up to function around them. You know, you walk into their office, there's a front desk person who gathers information from you. Then the nurse does an exam and gathers all sorts of information. They accumulate that in the chart. You read the chart, you knock on the door, you see the patient. It's really slick and efficient for you as that provider.
But Alan, I was gonna say really quick, sorry to interrupt, but as of 6 weeks ago, my doctor, I had 3 appointments that occurred on 9/11. Sorry, that was 6 weeks ago.
Yeah.
And they basically called and said, we don't want you to come to the office. You can do FaceTime, you can do Skype, you can do whatever you need to do to talk to the doctor. They're okay with that. I have many friends that are out there. They are looking at Teladoc for the last 2 years. They need a Teladoc installed within a week, right?
Yeah, no, totally.
Right?
By the way, doctors are the absolute worst people in the world because every doctor is their own CEO. And managing change management with a doctor is like a nightmare, right? And so they were placed in a situation where they could put their hand in a fire and have patients who could potentially infect them and kill their family come into their office or use this other technology. And surprise, surprise, they decided to use the other technology.
Well,
are we going back? But are we going back? But Gary, are we going back?
We also think about, to your point, Alan, we also think that how I've heard lots of friends of mine complain that they go to the doctor office and they visit, and that doctor never even looks at them. That doctor has his head buried in his computer because he's entering the notes of the questions he's asking without even turning to direct to the patient. So they might as well be asking the patient the questions over a video.
So I wrote a blog piece years ago called "Your Doctor's Not Ignoring You, They're Playing a Video Game," because the EMR has become the third wheel in every visit and has become such a distraction. It has eroded the doctor-patient relationship. We've become slaves, we've become scribes, slaves to the data. It's
but
ridiculous.
You can see how the technology can make a big difference in especially some patient populations. There are going to be some that have to come in and be tested, either for some asthmatic situation, some allergy situation, requires some sort of physical interaction. But there's a lot of regular visits that do not necessarily have to be done, you know, in person. And so those, I think, this can provide sort of an alternative. And I've listened to a bunch of, you know, doctors that have put this in their practice and they've been doing it for a while now. And they're like, you know what? 50% of my patients, I don't need to see all the time. So I can give them service by seeing them almost more often because of this capability. But I don't need to see them physically in person.
No, 100.
And then if you change your workflow,
100%.
But Alan, if you change the workflow and you put in a nurse calls the patient ahead of time, or tele interacts with the patient ahead of time, gathers some information ahead of time, feeds the system. I think you can really see how this can change the doctor-patient interaction and almost reestablish a dialogue, assuming that they can gather that information through other methodologies.
Yeah, so there was a question that popped on my screen that came up real fast. So that 3 years ago, I would present, you know, I'm an early adopter and I would present telemedicine, and I always get bashed over the head about credentialing, licensure, and reimbursement. Those are the three things that would like, oh, you can't do this because blank, okay?
And parity.
And yeah, well, parity is reimbursement. So,
Right.
So recognize that those barriers were self-inflicted by us. It was not that this was not possible. It was that we had self-inflicted particular ways to pay for business and do business. And I do believe that now that the genie's out of the bottle and people have seen that this is something we can do, that those restrictions are going to fade away. They're not going to fade away right away, but they're going to fade away. I would also say that there are many specialties that, and by the way, forget about licensure for a second. You can take care of a lot of patients if you get out of your 5-mile radius, right? If you're just going to take care of everybody in the state of Arizona with a particular problem, you know, that's a lot of patients, a lot more than you have in your clinical practice without reaching into Nevada or New Mexico or California. So that's one. I think the idea of reimbursement has been overblown because particularly for surgical specialties, the way surgeons get paid is not based on the visit, it's based on the surgery. And telemedicine enables a bundled payment to happen more efficiently, where I can see that patient in triage and I can see that patient in follow-up remotely, but I have the surgery that they come to me, and it's better for the doctor's office. They have a smaller space, they have less FTEs, they frankly make more money, and it's better for the patient because they have to travel less. So I think now that people are, I mentioned change management, that's always what I think of whenever I look at a new company. How are we going to change the process that people are delivering care? What are you asking people to do? And that question has to be addressed. There's always winners and losers when you change.
So let me add a couple of things here, Alan. First of all, we've been talking about, let's talk about some of the other medical disciplines and where telemedicine has had valuable applications. So telepsychology, behavioral health. There's a lot of research that shows patients actually prefer consulting video as opposed to being in a doctor's office. And you can look at
teledentistry, right, as well.
Teledentistry now, where dentists weren't taking patients, and we're able to, and 9 million people a year go to an ER every year with an oral or dental health problem, and there's nobody there to help them. So they needed some help. But the other point you're going to raise is with COVID-19, let's look at what's happening. I think someone posed the question. Yeah, CMS made some major changes in what they're allowing to have happen with telemedicine now, and I have some concerns about it because they're allowing, there's no prior medical history being captured before doctors are doing consults, and that concerns me. Not all the calls, the video calls are encrypted, so they're not all HIPAA compliant, and CMS is reimbursing for telemedicine and even allowing doctors to do consults across state lines.
Wait, Gary, you said a term I'm not familiar with. You said something called HIPAA? I heard that's a historical term now.
Well, we used to remember that, didn't we?
Yeah, I mean,
Gary,
you have people talking about wearing like red or blue armbands now, telling you their viral status, whereas 3 months ago there was a question of privacy in healthcare.
Right.
I think we're really rethinking a lot of that as well.
But Gary, it's not going to, potentially some of it's going to stick and some of it's not going to stick, right? I mean, part of the thing I think we have to look at is, my viewpoint on some of this is that we are just, this 6 weeks ago episode that we're in now, it's just accelerating where we're going to go anyway, right? It just took, I'm looking at Teladoc for 2 years. Now I need to have it by Monday. It's how we embrace doctors. It's how we embrace retail drug chains. It's how we embrace groceries being delivered to us. It's how we embrace the new kind of normal that's out there as well. So I don't think we're gonna get rid of HIPAA, per se. I do believe that the 1135 waivers that are out there state by state of being able to see doctors, over state lines or take care of patients over state lines, I think that will stick. I think reimbursement will stick. I think consumers and physicians will demand it. So one of the questions I had for you, Gary, or for Harry on this is, how are doctors adopting to this? I mean, 6 weeks ago, I felt like doctors were a little bit uneasy about telemedicine and telehealth because they thought that may be taking away from their practice. Now they're embracing it big time, right, from that. What's your thoughts, right, going forward?
Well, not all doctors have, I'll use the appropriate word, video bedside manner.
Yeah.
They don't know how to talk to a patient through a video screen, and that sometimes makes them uncomfortable.
Well, I would say, like,
ahead.
you have places that have, you know, like I said, systems in place that sort of make it easier, and they're used to the process. I think this is a learning process. I think that as physician practices implement this, you know, a couple of things they need to think about is, how do I refine the process, right? How do I, like I said, maybe have somebody contact the patient ahead of time and ask them simple questions like, you know, do you need a refill, or what are your concerns today, or whatever, and capture some of that information ahead of time so that the visit ends up being a visit, right? An interaction between the physician and the patient. But I think there's going to be some tremendous good out of this, right? I mean, I can already see how this is: a resident comes in, starts interacting with a patient, begins to learn on the job in this way. Physician comes in, joins. Now you've got a physician, now you got a resident, and you got a patient, and you see that as a learning opportunity that you might not get under the regular circumstances of running around.
So Harry, really quickly, can that be machine learning? Can that be AI that's a chatbot? Can that be, you know, some assisted technology that's helping with that and preparing it for the physician? What role is ML or AI going to play in all this?
Well, there could be. I think that you'll start to see an advancement. I mean, there's already some of the systems that we're transcribing and putting into the EMR that are now having to adapt themselves to a phone conversation. You're already seeing this stuff starting to be implemented in Zoom, where it transcribes your entire conversation. So the next step is then being able to, you know, implement that into an EMR. But I mean, Kent, I'm already looking at technologies that will be able to look at, you know, be able to tell infrared, be able to tell temperature, be able to tell blood pressure just from what's on your camera.
Yep.
So there's going to be a lot of technology that's going to, tricorder wise, that's going to add to the visit, let alone all the diagnostic technologies like Tidal Care or anything like that that can be in a patient's home that can be additive to the entire visit.
Can I add a few words on this, Kent?
Yep.
So the AI, ML, and, you know, artificial intelligence ML space clearly has an opportunity to play in the space. So probably the best known company in this space is Babylon Health out of London. I'm actually advising, just as point of disclosure, a company called Telemedicine Health. I'm functioning as a chief medical officer out of Silicon Valley. The idea of a bot sitting in front of a patient using AI to ingest your personal information and then have directed questions for that patient, so that what ends up happening is we take the 15-minute physician visit, which is usually 12 minutes of data gathering and 3 minutes of conversation and next steps, and we flip that so that it's 3 minutes of confirmation. Hey, you had this confirmation of this data, these questions that were asked of you, and now let's spend some time and talk about how do you feel about that? Our humanity has time to get back in the clinical visit because we have these assist devices. My personal belief is that the way you get to really robust telemedicine is you create a cockpit. And so when you think about brick and mortar versus telemedicine, which, you know, for the last decade and a half has been, oh, it's never as good as in person. My question is, well, can it be not as good? Can it be better? Because I want to put all these tools, toys inside the virtual environment that helps the physician arrive at the right diagnosis in a very short amount of time, based on AI bots, based on facial rec for things like, are you depressed? Can we put other layers on top of this? Can we do other things that may allow a patient to talk to the bot for 45 minutes to an hour, where they not only do data aggregation, but they also do education. But so by the time I come in the room to see that patient, they're already as to what's going on.
Yeah.
And
I was gonna say, go ahead, finish up. You cut out there for a second.
To me, that's what the future of telemedicine looks like. It's not competing with brick and mortar. It is something better. And you solve that supply side issue by making it a better experience, not for the patient, but for the physician, who then says, I'm willing to give up my practice and move to this environment because in this environment, all this technology is assisting me in having it sounds ironic, assisting me in actually having a better conversation with my patient.
Yeah,
I'm just looking.
Kent,
Go ahead, Eric.
Kent, when I go into my doctor, right? I mean, I take my phone and it's got, you know, my blood pressure over time. It's got my weight over time, right? I mean, now I can start, you know, my Apple Watch can give all sorts of cardiac data, right? But I can go in and sort of, he can get a picture of me, not just at that moment that I'm there, but over a longitudinal period of time. I think that's going to change the way that we practice. It's going to be wellness care, not sick care.
Yeah, I totally agree with you. And things I'm looking for coming forward is things that just make it more simple for me, anticipatory, right? From that, remembering when to order my medication, knowing when I need to get a flu shot or a pneumonia shot that's out there, knowing, you know, when to go over my vital signs as well, from that as well. Those are the things that I would like to have AI drive me a little bit more in a background way, right? To kind of assist me, you know, from that, so that, you know, I don't have to remember it myself on it. I want to get to some questions that are coming in from the panel. I've seen them come in along the way, and there's a lot of questions coming in, but there were some questions that came in before about the role of diagnostics and labs and results, right? That are coming in remotely as well. Now, one example I always give is here in town, Sonora and Quest. I tried this actually about 2 months ago, where I was going to my doctor, my GP, and I'll say this really quickly, that I stopped going to my general physician about 5 years ago because they were making me come in for an exam, then come back for tests, and then come back for results. And that's how they were paid to be able to do that. So a lot of us around us went actually to, you know, take care of more of ourselves and going to, you know, to Ready Clinic or Minute Clinic or other places if we, you know, got a cold or a sniffle, right, that's out there. But what I tried 3 months ago was doing a telemedicine visit. They ordered a lab result. They gave me the form for the lab result. I sent it to Sonora and Quest. They came out to, they came out to my work. They did a blood draw, and the results were back in my chart within a day, right, from that as well. So I didn't have to leave my office at all to be able to see a doctor and then actually get the lab results. So what role does the lab play in this? What role does diagnostics play? Now we're seeing multiple arrays, assays that are coming out with 15, you know, different assays per strip that's out there. What role does that play with telemedicine and telehealth going in the future, guys?
Well, I think it adds to the practice of medicine, just like it always has, right? I mean, I forget what you'd think I would remember the statistics, but it's like, you know, 87% or 89% of all decisions come from laboratory results that come back to a physician, right? So, you know, you need to understand blood pressure and, you know, heart rates and temperature and all these things, but all of these now are enabled through a digital device that is wireless, connected, and can get information out. I mean, if you need a urinalysis, you know, there's a company out of Israel, which I cannot remember the name of right now, but you take a picture of your analysis chart and automatically does the analysis, right? So there are technologies that are lending themselves to remote monitoring. Now, would I want somebody doing an oncology test remotely? Probably not, right?
Yeah.
But there are a number of things that on a regular basis, I think can be managed with a diagnostic associated with a qualified physician that will be able to manage that person. And believe me, don't think like this is if you think about what CVS and Aetna are going to do, their entire business model is going to be get you into their clinic, diagnose you or manage you. And if there's an issue, a doctor is going to show up on a video screen and deal with you right there. They don't want you going to the institution because then Aetna has to pay and it's a loss for them. So if the industry itself doesn't change itself, somebody like CVS and Aetna will cause a functional shift and a change in revenue model.
You're right.
On the industry,
Harry, because that's how you mentioned it. The reason that managed care got involved is because they realized how telemedicine can save money. It saves money for the patient. It saves money for the managed care company. And they would much rather have, Teladoc's big success was the contract with Aetna, where they took on all their customers, and Aetna said, I'd rather pay a $35 consult than $1,100 emergency room visit.
But Gary, I'll go one step further. If you look at the Affordable Care Act and where it's going to wellness payments, right? To pay for outcomes, is if you are not monitoring and you're not measuring and you're not getting ahead of it, you're going to end up on the wrong side of that.
But there is a fine line, Harry. As we talk about data, and Alan talks about, what can be monitored on a regular basis, the chronic care person, the diabetic. There are a lot of doctors who don't want to be inundated with data on a daily or weekly basis for a patient. They want a trend line. They want a summary report. If Wald's glucose is out of line, okay, well, they want to know about it if it's happening on a regular basis versus, and right now there's not a system. The systems that are built to send to the caregiver every data point, and I think we need to be more careful about that.
So I believe that we do need data that's out there, but the doctors don't need the data. The AI systems and the ML systems need the data. They need to see massive amount of data to be able to look at trends and to be able to actually present it to the physicians in a meaningful way. That's at least my viewpoint on it, right from that. So that's why we're in business, is actually go get the data very economically out there to be able to bring it back to the AI systems. One of the questions I had, and anybody can push back at any time, obviously. One of the questions I had is, the rumors have been that Amazon's going to invest close to $500 billion into healthcare. You all start talking about, the new normal in healthcare. What's Amazon developing in your mind? What are they coming to market? You talked about CVS and Aetna. What do you think the new consumer approach is going to be with Amazon?
There's really 3 plays at Amazon. So Amazon has Haven, which is their insurance company, which is kind of walled off from the rest of Amazon. Most people think Haven is going to, frankly, kind of muddle along. We haven't heard a lot about Haven of late, but that was the Berkshire Hathaway, Amazon, I can't remember, JP Morgan, someone else came in, and it's kind of muddling along. The next you have is Amazon Care, which is a service that's been developed, looks a lot like Teladoc might look, but it's strictly for Amazon employees. I think they're going to do a try and buy on Amazon Care, where they practice on Amazon Care with their own employees to try to figure out primary care wellness, and then debate about whether they want to globalize that service as Amazon. What I think is missing from that conversation is really the question of where are they going to get the providers? Amazon historically has not been a company, it's a tech company. It doesn't hire large provider groups like Teladoc or American Well has done. So I personally don't believe that Amazon Care is going to develop into a competitor for Teladoc. It may be an enabler of a competitor to Teladoc. And then the third place is AWS, right? And that's the life sciences. That's what my friend Dr. Bartovi's running. And it's funny because I've gone to meetings at Common Spirit where the title of the presentation will be, is Amazon going to eat your lunch? And I don't believe that for a second. I do not believe that you should be afraid of Amazon. However, you should be very afraid of your competitor having a better relationship with Amazon than you do, and leveraging exquisite, elegant, sophisticated tools to improve care delivery. And so the reality is, you as a large IDN, as a large deliverer of care, need to figure out who are you going to put in your corner to help you manage these tools and grow exponentially in a rapid way to compete in the new reality. Every space in medicine is being redesigned, re-envisioned. So, we're really struggling because hospitals have tried to own the patient from birth to death by buying up clinical practices. That's probably a failed strategy, and hospitals need to stick to what hospitals do best, which is manage acutely ill patients and figure out how they get reimbursed for what they do best, rather than try to compete with Rite Aid, CVS. The list is endless of far more efficient providers of care. And so that really needs to be thought through. I think COVID, by the way, is going to drive this home, because you're going to see many hospitals, even though there's going to be billions of dollars poured into healthcare, you're going to see many hospitals that never fully recover from the hit that they've taken, the financial hit they've taken from COVID. This has just been a tremendous impact on my system, Common Spirit, huge system, 150 hospitals, but particularly smaller systems without big bankrolls, and the rural hospitals, they're just going to get smoked in the new reality.
Yeah, I was going to ask really quickly. I know we've got probably about 8 minutes left. With this goes fast. But Gary, from your perspective, do you trust the data that comes from the patient from the home, right? From that, I mean,
Well,
when you get it,
were you saying the patient completes a prior medical history before a consult is performed? Is that the question you're asking me?
or data's coming, you're asking them to read logbooks for their glucose readings or automated readings that come in from their blood pressure or given weight readings or whatever. Do you trust the information they're giving you, right, from that, or is that just one data point?
It's one data point, and you have to look at trend lines, I think. And if it's coming back, if it's the blood glucose is being transmitted wirelessly, other data is being transmitted wirelessly, so the consumer can't interject and change it for the most part.
Right. Go ahead, Harry.
No, I was going to say, Gary Allen, do you see when physicians shift to this, do you see incomes go up, go down? What are they spending a lot of their time on when they're shifting to this system? I mean, you guys understand the dollars and the cents.
Yeah, so I think telehealth represents a monopoly buster. So you can think about physicians and their practices, and historically, you didn't have to be the best physician. You had to be the best physician within 5 miles, because that was as far as a patient is willing to travel. It always astounds me that people will travel, 50, 100 miles to go buy a pot. But if they got to have their hip replaced or they need cardiac surgery, they're going to go to their local hospital. And it's like, you're insane. I actually think that hospital systems are equally guilty by every hospital offering every service imaginable so that they feel like they can compete and get contracts from insurers. So for any audience members, I strongly recommend, if you're going to have a procedure at a hospital, you ask that hospital and that practitioner how many of these you do. And if the number is relatively small, you run away. You don't walk away, you run away. Right. Telemedicine basically provides a leveling of the playing field where you can no longer be the best local practitioner. You have to be the best because everybody can meet online.
So we're going to see the same thing we see with realtors as well, that we're going to see with doctors, is that you're going to be able to pick the #1 doctor that's out there, like ZocDoc does, I guess.
Well,
right?
The most difficult thing is, how do you find that #1 doctor? What's the metric you evaluate that person and decide who's the #1? Because, most people, there is no real good rating system. And I think that's another piece that needs to be added, is transparency of data around outcomes. Most people rely on their neighbors who tell you how nice a particular doctor was, rather than the results they got. But ultimately, I think you're going to get there. And telemedicine provides that monopoly buster where an expert who is far away can now compete for your business and offer you better care at a lower cost. You've seen this with Cleveland Clinic and how they compete for cardiac patients. I think that's going to grow dramatically across this country.
Yeah, well, I don't know to what extent regulatory will come to play here. Will state medical boards have to change the way they think and act?
Well, you've certainly seen that break down in the time of COVID, right? Very rapidly. Compact legislations come forward. I can't remember the name of the state medical boards that basically, who were very reluctant to open up their borders, are now doing so. I think it is literally archaic and shameful that I can take care of somebody in Arizona, but the minute I step into New Mexico, I am no longer proficient in the art of medicine. That is completely ridiculous. And I'd ask the question, if I take care of a snowbird who's down here in Arizona in January and they call me with a problem in July from Minnesota, is my advice not valid anymore? And I know this person better than anybody. It is just so wacky. And I would actually ask the panelists one other question, and if one of you can help me, I would very much appreciate it. COVID has clearly identified the issue of federalism versus national healthcare. I cannot for the life of me think of another country in the world that has different rules of how you distribute healthcare by state, not by nation.
Right.
It's insane.
So here's a question. We all know that when you are doing something at this scale and you, like we've seen it, Gary, you said it's gone from one, from one extreme to the, like, I think too far to the other extreme.
Yes.
What do we obviously need standards in place so that this thing gives the best care and provides the best outcome. Where do you guys think the holes are?
I think you need an electronic medical record that's captured in whatever form that doctor reviews before they're performing a telemedicine consult. And I'm not a doctor. I'm just a businessman. But
did you stay at a Holiday Inn though?
Yeah.
I don't even play one. But you, Doc, what do you think about that? Because I'm nervous that this is a wild west. Let's do a consult.
Yeah, the biggest worry, the biggest angst I have over telemedicine is for the last decade and a half, telemedicine has largely been transactional. The vast majority of the business of telemedicine has been transactional. I have a problem, solve my problem, go away. Right? That's what Amwell's done. That's what, frankly, Teladoc has done. We want to get to a place where telemedicine assists in the practice of medicine, where it manages the continuum, where I have a relationship with somebody, I know them, I see them on a regular basis, and I make the right decisions about them. To your point, having complete information around a patient is absolutely essential to offering value. And we have not done that historically in the world of telemedicine. We've kind of chased the dollar, we've gone after the transaction, we've met the easy, low-hanging fruit, right? We were competing against urgent cares and EDs, as opposed to managing that patient over time and facilitating relationship.
Yeah, so we just have, this is great conversation. We just have about a minute left with this. What I really want to do is go around briefly and talk, to each one of you and just ask you, we've talked a little bit about it, but where is this going after COVID? So, Gary, where do you think that people are going to go back, to the way it was done before? Do you think it's the new normal? Where do you think we're going in the near future?
I don't think it'll go backwards. I think it will continue to go forwards. As doctors and patients understand how convenient it is if it's done correctly, telemedicine is the better solution, provided it's done correctly, provided the tools are in place, provided the video and the HIPAA and all the things that are important to respect, privacy and otherwise, are in place.
Okay. Harry?
Yeah, I would agree with that. All the right pieces need to be in place. I do think that you're going to see some people find exceptions that were done during this time and say, see, it's horrible. We should go back to more stringent regulatory moratoriums on it. But I'm hoping that if this lasts long enough, it's going to, it's not going to be able to go back. Somebody's not just going to be able to make it go back the way it was.
Do you think there's a difference, really quickly, I'm going to extend really quickly, but do you think there's a difference between how millennials and younger generation embrace telehealth and telemedicine versus seniors, right? And that's a really open-ended question at the end. I'm sorry about that, but thoughts on that?
No,
really quickly.
I think millennials are more, they will adopt technology much easier. But I will tell you that when seniors get used to something or they get proficient at it, they don't just drop it and go to the next program. They sort of stick with it for quite some time. And there's some studies that have been done with that. If you look at Evidation Health, which is a big digital health company, they've done a lot of work looking at trends like this.
Yeah, but you're looking at companies like Roman, Lemonade, and those that kind of come up for, HERS, HIMSS, that's coming up for, for the millennial generation and how they get their medicines and their supplies, through a telemedicine visit or a telehealth visit delivered to them. Are seniors comfortable, right, doing that, or do they want to see a doctor face to face?
That's the HERS, HIMSS, all those Roman. That's not healthcare. That's consumerism.
I was going to say.
Yeah.
Good point.
That's a completely different market that you're talking about.
Yeah, if you're worried about performance issues, yes, I would. Yeah, that's who you call, right?
Yeah, but you can go online and get, as a young adult, you can go online and get your birth control pills, right, and ordered by doing a a telehealth, consult with them to be able to do that. So I do agree with you, Alan, right from that. So let me just wrap it up really quickly. And, Alan, I want to go with you, right, about what you're thinking are about, going forward with telehealth, telemedicine.
So telemedicine is here to stay, and it's here to stay because the healthcare system is going to be under duress for many years to come. People are going to follow the money, and they're going to see this as a tool. I call healthcare compassionate capitalism because we're always going to take care of the sick and the underserved, but we have to have a sustainable, scalable business model to do it. Telemedicine is going to be one of those tools that allows us to reduce the cost of healthcare at scale. And so you're going to see, I believe, widespread adoption of telehealth because people now understand that this is a way that we can deliver care at a lower cost, and we're going to start doing it.
So really quickly, we're going to wrap up. I said that 3 times now. Alan, are we done with COVID-19 in this phase? Is it coming back in fall and winter and spring? What's your take on it really quickly?
We're not done with COVID at all. Trump can't wish it away, unfortunately, for all of us. Magical thinking doesn't work. If you look at the number of people who've been infected with COVID, it's still in the 3 to 5% range. And like every virus, it's going to have hot spots where it comes back. And when this happens, you're going to have hysteria, frankly.
Yeah, Harry, your thought on it?
Same
Gary,
thing.
I'll wrap up with you.
It's not going away. I've been trying to read, tons of papers, and we're still, just getting our arms around it. Although the Gilead results look good today, at least it's a step in the right direction. I am seeing some of the antibody, the SARS antibody modifications look like they're moving in the right direction. So I'm hopeful that by September-ish, we might have some ways of treating it. I am actually not very bullish on the vaccines. So I think it's going to be around for quite some time.
Do you think we're going to go through rolling quarantines or isolations in the next 18 months?
I've been hearing from some companies that some companies are saying they're not going to even think about sending people back to the office until September. I've heard other companies tell me they're going to wait till after the next flu season for non-essential employees and bring them back the following March.
Wow. Gary, your parting thoughts on that?
Well, I honestly don't know. I'm really sitting on the sidelines, letting the medical experts be a better prognosticator. I'm just hoping that the systems are in place if and when it comes back, better prepared than we were today, the first time.
Thanks. So I want to take a minute and thank everybody for attending this evening. I want to take a minute and thank our distinguished panelists, Gary Wald and Harry Glorikian and Dr. Alan Pitt for your participation and great insights as we implement telehealth and start defining the new normal in healthcare. I'm sorry that we weren't able to get even to a fraction of the questions. I'll be sending them out to our panelists to help contribute to some answers. But we will post the answers on the life365.health, the website, as well as recording of tonight's webinar. Please be safe and healthy. We look forward to having you join us the next webinar next Wednesday, May 6th at 7 p.m. It's called Support, Engagement, and Care of COVID-19 with Vince Camano, CEO of Peer Support Solutions, Neil Sofian, CEO of Tuzag, and Jim Bulling, CEO of Premedics. And actually, we might have a 4th panelist with his Alexa, that we might be asking Alexa about COVID-19 and how she would handle COVID-19 as well. So anyway, let's wish everybody a great evening and a safe evening, and thanks for joining us tonight. Thank you.